Hi, David Rosenberg here for the Psychopharmacology Institute. In this CAP, or Child and Adolescent Psychiatry Smart Take, we'll take a closer look at whether or not pharmacotherapy of childhood-onset psychiatric disorders increases the risk of future substance use and substance use disorders. In this comprehensive meta-analysis conducted by the Massachusetts General Hospital team, Weilands and colleagues do a deep dive, critically examining 26 prior longer-term studies, which included 21 studies of ADHD patients, 2 in pediatric major depressive disorder, and 3 on psychosis, which actually translated into about 6 million patients being included in their analyses. So this is comprehensive and a really well done, informative paper for clinicians practicing in the trenches with real world significance. So what did they find, and what are the key take-home points? Not only does pharmacotherapy for ADHD and major depressive disorder in childhood and adolescence not increase the risk of substance use or substance misuse or substance use disorder, there was a striking and significant reduction in risk of developing substance use disorders by 30% or more. This effect was actually greatest when pharmacotherapy is initiated earlier and kept on for longer duration. There was also a signal suggesting reduction in risk of developing substance use disorders with medication treatment of bipolar disorder and psychosis in youth. That being said, the most pronounced reduction was seen in patients with ADHD. And this is a huge finding, given the concern often voiced about the potentially addictive effects of ADHD treatment, particularly the stimulant medications. Here, in this well-done study with a large sample, this data strongly suggests that when stimulants and other medications are used for the appropriate indication, in this case ADHD, at the appropriate dose, that not only is the risk for future substance use disorder not increased, it actually significantly decreases, which actually makes sense when we consider the symptomatology of ADHD and that effective treatment may improve impulse control and other symptoms that could result in increased risk of disinhibition and experimenting and using substances, as well as the eventual emergence of substance use disorder. So very, very promising. There are some caveats to consider. For ADHD, the stimulants, of course, are often the treatment of choice, but even with evidence suggesting a reduced risk for subsequent development of substance use disorders, caution is needed, particularly in some high-risk populations. So I'm always very cautious about using stimulants in ADHD patients, for example, who already have a comorbid substance use disorder. There, the risk clearly goes up, and it's not clear that the stimulants, in fact, are as effective in that population. Likewise, in children and adolescents with a first-degree relative, a parent, a sibling who has comorbid substance use or actually has significant substance use disorders, I am inclined to avoid the stimulants in most cases because these are high-risk populations and non-stimulant alternatives are often preferable in this population. Now, with the extended release preparations of stimulants, of methylphenidate, amphetamine, that risk of abuse is decreased. But we've all heard about people, particularly with immediate release stimulants, but others selling Adderall, using Adderall and stimulants inappropriately to do better on an examination. I myself have been called by people that I know, friends, others in the community, asking if I would be willing to prescribe Ritalin for a son or daughter who's taking a big test like the SAT for college. And of course, that's completely inappropriate. And what I always say is that I'm perfectly happy to do an evaluation and see if a medication is indicated. But as we say in our textbook in child and adolescent psychopharmacology, the best predictor of a good treatment response is an accurate diagnosis or diagnoses, because so many of these conditions have comorbid conditions associated with them. That sounds easy, but as those of you who practice in the community know, that's harder than it sounds. And oftentimes it takes a longitudinal assessment. The situation can change as more information becomes provided. There are some limitations in this analysis, particularly that comorbidity was really not addressed. And we know that ADHD, major depressive disorder, psychosis are highly comorbid conditions. So this is important. The analysis also didn't really focus on psychotherapies, which are often used in the treatment of these conditions. They didn't look at all at psychotherapy only treatments. And they also didn't really examine medication plus psychotherapy, which, at least for some conditions, has been found to be the most likely to result in symptom reduction and even symptom remission as compared to medication alone or psychotherapy alone. But the bottom line here is that this is an excellent, clinically relevant study with immediate implications for those of us practicing and seeing patients in the trenches. And it really appears that pharmacotherapy in childhood onset psychiatric disorders not only doesn't increase the likelihood for substance use, misuse, or substance use disorder, but may in fact significantly reduce this risk, especially when medication is initiated early and for longer duration. So a very exciting, important, and understudied area, which is directly applicable to practicing clinicians in the trenches with important information for us to disseminate not only among our fellow clinicians, but to patients and their families.